fluctuates. They are not always there. Sometimes we can do things, and other times we are much worse. This leads physicians and others, including our family and friends, to disbelieve us. Not only can we be denied proper evaluation and care, our very support system doubts our symptoms. What's more, we often begin to doubt ourselves. This can be extremely devastating to the very core of our being. We know something is terribly wrong, and we struggle to find help, as our lives may be falling apart around us, including our families and our careers. We hope for a provider who will listen and try to help us. It's not uncommon for us to be told we're simply depressed or anxious. When all of our tests come back normal, no one may continue to help us search for answers. In reality, having a chronic illness in general, especially one that no one is believing, is a source of depression and anxiety. We may be labeled with conversion disorder or functional neurological disorder. When these labels follow us to new providers through electronic medical records, their judgment of us can be clouded before ever even examining us. These labels also have many ramifications as to how our families see us and how we see ourselves. Our journey to diagnosis may be very long and difficult. When answers are not immediately clear, we need more testing and more conditions must be ruled out. We may wait a long time for answers without the reward of any relief from symptoms or even clear knowledge of what is wrong with us. Sometimes physicians will not treat us without having definitive proof, even when we have clear symptoms. We don't have that proof to offer, but yet here we are. This is our reality, and this is where we find ourselves. More conservative has often been due to the lack of uncertainty of our diagnosis or availability of treatment to seronegative patients. Sometimes current treatments that have been working are pulled if we are faced with seeing a new neurologist. And finally, we have more difficulty with appropriate emergency care, even when we have reached the point of nailing down a diagnosis and are receiving current treatment. This makes us fearful and less likely to seek care in the emergency room. We fear being told yet again, your test has been negative, you don't have myasthenia gravis, or you are just having an anxiety attack. This may lead to a lack of even proper assessment, lack of any care at all, improper care, or at times patients being sent home when an ICU admit is appropriate and needed. There are also times we are told we are fine because all of the tests done in the ER and needed necessary ventilatory support is not given until after a patient fully crashes. These issues are not things we can put out of our mind. Our lives and our functioning depend on the care we receive. We ask ourselves, how do I find the help, and how can I help my doctor help me? All this as we struggle against the thought, is all of this really just in my head, as others around us may believe? This is the truth of having seronegative myasthenia gravis. What Charlene and I hope is that you leave here tonight knowing that you are seen, you are not alone, and there is hope. So with all of that being said, that kind of brings us to the very first question we had. for Charlene tonight. And just a little back history on that. About a year and a half ago, Rachel Djokovic, Rachel from our Seronegative support group, and I contacted Rearmark, which is a rare disease foundation, and we wanted to try to get some useful, reliable information. They agreed to help us by helping us create a survey. Rachel worked very closely with them, working on the questions. They did the data collection, all of the mathematical word finding glitch, all the mathematical stuff needed to get results. And what they found is out of over 100 participants, over 50% they already were diagnosed with seronegative myasthenia gravis, but their antibody tests were, of course, negative, but also their repetitive stim test and their single fiber EMG testing were also negative. These patients were diagnosed clinically. So our very first question tonight for Charlene would be, many of us have classic myasthenia gravis symptoms and respond to the usual myasthenia gravis treatment. Yet we remain negative on all testing, including our antibodies, our repetitive stimulation, and our single fiber EMG. Does this really mean we don't have myasthenia gravis?
So sometimes, but what we want to do is tonight go through some of the diagnostic dilemmas that we face when someone is not positive for the diagnostic test to confirm myasthenia. Where else should we be looking? And then how do we treat? One of the things, what I wanted to do is we have 3 or 4 slides of, so we're back on track. We have 3 or 4 slides to go over that have the usual way that we make the diagnosis of myasthenia gravis. And the first thing that we do is we look for antibodies. And the most common one that we look for is the acetylcholine receptor antibodies. These are found in about 50% of people with ocular myasthenia. So that means about half of the people do not have antibodies. In people with generalized, which means the symptoms go beyond the eyes, these antibodies are found in about 60 to 65% of individuals. And you can see in part 2, there's an antibody, an acetylcholine receptor antibody binding to an acetylcholine receptor. Which these leave about 35% of people who don't have the antibodies. So when these are negative, we start the search for other kinds of antibodies.
The low affinity AChR antibodies that you have listed, that those are something that I've heard about, but I don't really have a good understanding of.
Yeah, so a lot of people don't. So typically when we do a assay for antibodies, we take the blood and they process it where they have it bind to a plate or to some type of mechanism that allows us to look for those antibodies. But sometimes those antibodies do not bind tightly, and so they get washed off as they're doing the procedure that looks for the antibodies. So there are actually assays that they do in England that are looking for antibodies that bind less tightly, and so sometimes that will increase the yield of looking for the acetylcholine receptor antibody. There are other antibodies that we look for. One of the ones that we found about 10, 15 years ago was something called MUS, and that's a muscle-specific kinase. And individuals who are MuSK positive have a slightly different presentation than those with the acetylcholine receptor positive myasthenia. And they respond to different therapies. So as we're looking at these other antibodies like LRP4, the agrin, rhabdin, these are other proteins that associate around the acetylcholine receptor. These are ones that as we start learning more about the seronegative and individuals who have these proteins, what we hope to do is come up with a clinical picture that'll help us kind of hone in on those individuals who have these antibodies, and then how do we how do we treat people with these antibodies more appropriately. So this is going to be one of my calls, is to make sure that everyone is registered on the registry so we can learn more about what it means to be seronegative or to have these other antibodies. So the antibodies are one of the ways that we make the diagnosis of myasthenia gravis. We have other means of making diagnosis. And so I'm going to go ahead, Sherry, just because of time. So seen below, we have a picture. If you look on your left, there is a gentleman who has ptosis and has a bit of facial weakness. You might not see that with his before picture, but it's quite obvious after. So one of the tests we do is something called an ice pack test, where we'll take a baggie of ice with a little bit of water in it to create a slurry, and we'll place it on the eyes, over the eyelids, for a few minutes. And with the cooling, you'll actually see an improvement in facial or ocular strength. And we used to do something called a tensilon test. So many people who were diagnosed many years ago may have had an IV test, which is the IV. Tensilon is the form of IV form that's equivalent to our Methanol. And with this, it's a very fast-acting acetylcholine receptor, or acetylcholinesterase inhibitor. So we would see improvement in the clinic like you see with this gentleman. And then after it wears off, he goes back to how he looks before. So given that we don't have the tensilon, and there are side effects like a slowing of the heart rate, we don't do this in our clinic anymore. So we actually will do a Methanol challenge. So taking a picture beforehand and then waiting about 30 minutes and see if there is a clinical benefit. So did you have some questions, Sherry?
Oh, just in general with that, so if either one or both of these tests are positive, can that actually confirm a diagnosis of myasthenia gravis, or can they be positive in other conditions as well?
So with the ice pack, there aren't that many other tests that may be positive, but this is it's actually a nice indication that it shows how the muscles are sometimes heat sensitive with the myasthenia and how cooling can help. But with the Methanol, there are other diseases that can improve. So some of the muscle diseases may improve in neuropathy, maybe not to the same degree, but it has shown benefit in some other conditions. So if there is a positive response, it's not 100% that this is myasthenia gravis.
But it still can be useful in making that clinical picture.
Right, so it can help. And so it's one more piece of the picture that we look for with myasthenia. So there are other tests, electrodiagnostic tests that we do. And this is something that people come to a nerve conduction, our EMG lab to get. And what we're looking for is clinical or electrophysiologic evidence of fatigue. So just like many of you have had testing where we'll check your strength and then we'll come back and do it again, or we'll have you sustain an activity like holding your arms out or looking up. We do this electrically to look at the response of the muscle. And if you look at the top tracing for the person who is normal, and need to get the glasses, for a trapezius, which is a shoulder muscle, at rest you can see that all the motor responses look the same. So then that muscle was exercised for 90 seconds because that's something that will bring out the fatigue. There was actually no evidence of fatigue. However, when they studied this person's diaphragm, at rest the responses showed no evidence of fatigue, but after 90 seconds of exercise, which would be a fast kind of breathing in this case, there was actually, you can see the motor response starts to decline. So this is one of the tests that we use. This can be abnormal in other nerve conditions. So it's not specific for myasthenia, but it helps. And one of the things we look for is to see if that motor response drops by about 10%. How do we make the yield of that test better? Because things that we do is heat. So making sure that the room is warm when we do our studies. One of the things we ask is that people come into the clinic without taking their Methanol. So we ask that they hold it overnight, or if they're doing a test in the afternoon, to not take their morning dose, because the Methanol will make people stronger, and we'll see less of the fatigue electrically. So there are often we may need to repeat this test because we want to control for the conditions. The below tracing shows a single fiber EMG. This is something that we do after the repetitive nerve stimulation if we don't see a positive response, and sometimes to understand the clinical severity of disease, because this correlates with the severity of the myasthenia. So we place a needle into a muscle, and we have someone very gently activate the muscle, and we can look at what we call the nerve-muscle junction of two different muscle fibers that are supplied by the same motor nerve. They should fire all at about the same time, which is what you see with the normal. So we have one unit, and we're looking at a second motor unit, a second fiber very close to it. When the neuromuscular junctions are not working, the response comes at a very late time, which is what you see with the widespread of those potentials. And then the second thing you see is sometimes you get a flat line. So if the neuromuscular junction is injured to a severe degree, you won't even get a response, which is called a block. Now, this is a very sensitive test, and this takes about this is positive in about 95% of cases of myasthenia gravis. And so, this is one of our gold standards. But it's not done at all centers. And many times people may want to repeat this in their own hands, especially if it's done in a muscle that's not weak. You want to make sure that you're controlling the conditions to make sure that someone is not on Methanol. So, in terms of other diagnostic tests, so when I'm going down the route of myasthenia gravis in terms of diagnosis, I will do a chest CT. And if you look on your left, this is a chest CT, and it's done with contrast. And if you look at the top, that's the sternum. So in the front of the chest, and you can see in the bottom is the spine. The bright white spots, or the circles, are the great vessels, and in front of those vessels is a lighter gray color. That's actually thymic tissue. Now, there's people say, I don't have a thymoma, so there's two different things that we're looking for. One is Thymic Hyperplasia, which means that the tissue has grown more than it should. So normally the thymic tissue will disappear after adolescence, so in your sort of late teens, early 20s. So that's what it'll do is it shrinks, it goes into the fat. So we shouldn't see a plump thymus like we're doing. So the question is, should we do this with contrast? We always do, because that allows us to see the vessels and to define it better. We can look for other things that may be causing shortness of breath. We can look for inflammation in the lungs. We want to make sure is it some type of infection or other lesions. So we always like this with contrast.
One question that this is a really important issue for seronegative patients because we hear different things about it. So if the chest CT on a seronegative patient does not show a thymoma, should someone still think about having a thymectomy? And what would play to that decision?
Yeah. So one of the things, if someone has a thymoma, they're going to talk to their chest surgeon, and we do want to take that out. If it shows thymic hyperplasia, this is something that you need to discuss with your neurologist. And so if we see thymic tissue, we may be more inclined to take that out. The big question comes when someone has seronegative and you don't see thymic tissue, should you still do a thymectomy? And that's a more difficult question. That's on a case-by-case basis. And you really want to see more evidence of this being myasthenia. And so you may be more reliant on the clinical history and the clinical exam over time, and then making sure that we've excluded everything else.
Okay. Thank you.
So this is the big thing. So once the antibodies are negative, where, their antibodies are negative, the repetitive nerve stimulation is negative, the single fiber is not positive, there's no evidence of any thymic tissue in the chest CT, now what do we do? So there are so many things that can look like myasthenia. And one of the real common things is some of the muscle disorders. Many of them, they only involve motor symptoms, so they're not going to have sensory or other things that may suggest some other type of disease. They're generally progressive, so they worsen over time. Where they differentiate from myasthenia is myasthenia has this component of fatigue that's variable across the day and with sustained activity. So yes, people with muscle disease will get tired and the muscles will fatigue, but you're not going to see that variability like you do with myasthenia. Muscle disease will most often affect the shoulders, so people will have difficulties lifting overhead. They'll have troubles with hip weakness, which is very much like myasthenia. Some in the means with all of these that you can have them seen sometimes. Sometimes you'll have weakness in the hands. The distal muscles are the hands and the feet. Sometimes muscle disease can affect speech and swallowing, just like myasthenia. And there are some that can affect double vision and drooping eyelids, like mitochondrial diseases. There are some muscular dystrophies. And then, just to add some confusion, there are muscle diseases that can worsen with exercise. So often, I end up doing a muscle biopsy in folks that I do not find clear evidence of myasthenia gravis.
And what about genetic testing? Is there a role for that?
Yes, so a lot of times I will do genetic testing, both looking for some type of muscular dystrophy, but also looking for some of the congenital myasthenia gravis. So those are two of the diagnostic tests that I will often do. And I have found a number of seronegatives that end up having congenital myasthenia. there are other things. Many people with myasthenia will get diagnosed with stroke, especially at the early onset. They'll have trouble chewing, swallowing, have evidence of weakness, facial weakness, and so many people have undergone a stroke workup for their myasthenia as their first encounter with neurologists and medical specialists. Multiple sclerosis can present with many of the same symptoms. There are nerve diseases like Guillain-Barré syndrome that can present with sudden weakness, troubles chewing, swallowing, troubles breathing. And one of the ones that I think is very important is vasculitis. So the people with myasthenia often have other autoimmune diseases, and many of the autoimmune diseases can affect many organs. And so sometimes nerves, like lupus and rheumatologic, and some of the rheumatologic diseases can affect nerves that affect the face and cause facial weakness. They can affect muscles. So it's one of the things that I want to look for. Lung disease, with shortness of breath, we want to make sure there's not something going on in the pulmonary system. Heart failure can cause troubles with fatigue, so we always look at cardiac disease. And anemia is one of the big things that will cause fatigue, weakness. So we really want to look for many things.
And sometimes, because so many of us have more than one condition, can that problem for a doctor to kind of distinguish between what is causing what symptoms when they're going about diagnosing?
And that's so very true. And so that we're going to actually bring up as we look at treatment, because what we really want to do is look at each of the symptoms and make sure we're treating the right thing. So one of the things that in looking at seronegative, patients go through in my mind, a much more significant workup because they undergo a lot more tests. And so to counter Sherry's, or not counter, but just to, in seeing a patient who's seronegative, one of the things to do is it may take more than one visit. And so one of the things that I think is important is, and often you're going for a second opinion, third opinion, or in some cases maybe sixth or seventh opinion. And so there's a very large volume of records to review. And I think it's important to go through that history. So what I have is the points on the side are, I think it's important to obtain your records and make sure that your physician you're seeing has those records. It's helpful if you can organize those so that they can go through them logically, organized by their imaging, like what CTs have you had and MRIs, and then what, if you've had electrical studies, we like to look at the raw data to make our own impression. And then to create a timeline that you write out that's easy to follow so that doctors can understand the evolution of your symptoms and get an idea, did this come on quickly? Did it come on over a longer period of time? It's very helpful to know the medical trials because you've been on many medicines many times. Let's try this. Sometimes those trials are not at an adequate dose or an adequate duration. So if you have that information, that's very helpful when you come in. Did you respond? And did you have side effects? So that'll help speed up your visit, and it's actually a nice thing to have as you're seeing multiple doctors. It takes more time because we're searching for alternative diagnosis. You know, we do need to look hard. If we're treating you for the wrong disease, there are many side effects. And so we want to make sure we're doing the right thing. We need to explain the symptoms that we're seeing and what they mean to us and how they fit and how they don't fit. It's going to take a lot more time for counseling because you have to order additional tests. There are risks with each therapy. and with each diagnostic test. So going through those. Without a firm diagnosis, the risk and benefit is much higher in terms of the risk, because if you're treating someone, for example, with an immunosuppression, which it suppresses the immune system, you're more at risk for infection. And if you don't have myasthenia, that may be an inappropriate therapy for you and can cause significant side effects. Sherry and I were talking before this, the lines, doing continued therapies with IVIG or plasmapheresis, if you have a line inappropriately, this is an increased risk for infections or blood clots or other types of injury. So, so these are important things to sort of, I think, put into context so that you can plan for more time with your physician, help them out, with this information up front. Also dealing with frustration. So when people have seen 6 and 7 physicians, they don't have a diagnosis. It's hard. It's frustrating on your end, but coming to a consultant to get a fresh look, start with a clean slate, tell the story in a different, tell your story again, and someone may be able to see things in a different light and may be able to say, I've seen 3 or 4 cases. I think you may have this instead, or in another case, they may say, yes, it does look like myasthenia, seronegative. So seek out a second opinion, but see it as a fresh look. The other things, establishing a proper diagnosis. So with seronegative, my patients and I have a long chat. These are things that fit for myasthenia. These things are ones that we don't. And so we're going to keep an open mind. We're going to, when there are symptoms that need treated, we're going to treat them, but we're going to keep looking for other things. And the bottom slide says keep the risk balance, balance the risk-benefit profile. So make sure that we're doing the right thing, reduce the risk of infection if we're using immunosuppression. There are risks to organs such as liver and kidney when we use some of the steroid sparing, and steroids have a lot of side effects. There are cancer risks with some of these medicines as well. So these are things that we have in our minds as we're either not kind of withholding treatment, but when we're being conservative, we're making sure that we're trying to do no harm. So having an honest relationship with your physician is so important. So treatment is very similar to what we do with myasthenia and seronegative. We use the same agents, but we really do a lot of symptom management and support, and we do this with a seropositive myasthenia as well. I have 3 other slides, and what I think we should do is we're at 8:55, I believe, so we should actually, I think, take the questions and answers. And one of the things that we were thinking is that we may need to do a second one to talk about treatments and symptom management. So I think we can maybe say that for another time. I think it's important to take questions.
Okay, so I'm going to ask everyone, a lot of you have already put questions through the chat box, which I've gathered, so I have them here and I'll pose them. If anybody else has questions, I please ask you to pose them through the chat box, and then I can pose them to the presenters, just because we've been having some audio issues. So just please encourage folks, put your phone on mute, put your computer on mute, and pose any questions to the chat box, and then I can ask them for you, okay? We'll get started. Give me one moment. So the first question that we have is from Cassandra.
what are the main other conditions that respond to Methanol?
So some of the muscle diseases will, and some of the neuropathies will, but often to a lesser extent. So.
Another question that we have, please put your phone on mute. I'll ask folks, *6 or your mute button. Question that we have from Sarah is, can neuropathy cause ptosis and facial weakness that improves with methadone?
So neuropathy can cause ptosis, and it can cause double vision. And one of the things is something called a third nerve palsy. So many things that can cause neuropathy, a lot of the inflammatory, there are certain infections and diabetes that can affect single nerves, so they can cause it, but you don't often see the fatigue of those muscles like you do with myasthenia. And they may get a little better, but not to the same degree myasthenia does.
Thank you. And another question, so we have quite a few, so we'll try to get through to all of them. Do we need azithromycin or other medications?
What medicine? Say it again.
And I may be mispronouncing it. I apologize. Azithromycin? Oh, azathioprine?
Oh, azathioprine. Okay.
My apologies.
No, that's okay. So azathioprine is Imuran, and so that is one of the steroid-sparing agents. So our first line of therapy is Methanol with myasthenia because it works so quickly. It works when it's absorbed. And so that's our first line. The next thing that we often do is start immunosuppression if that's appropriate. So generally we start with steroids unless there's a medical problem, and that's because steroids will work within 2 or 3 weeks, so they work much faster than some of the steroid-sparing drugs like azathioprine, mycophenolate, cyclosporin. So we have a number of medicines that we can reduce the side effects of steroids and still suppress the immune system. So that's something you want to take up with your neurologist, and we're always looking at risks and benefits. So, but that will take several months to be effective. So if you're having problems that are bad, you need something that's going to treat the myasthenia much quicker. The long answer, sorry.
Thank you. From Pam is, would Botox cause a false positive FEMG after 7 months?
Not after 7 months. So the Botox does take a few weeks to interfere with the neuromuscular junction, and it does it on the nerve side rather than the muscle. But at 7 months, the neuromuscular junction should be repairing. But if someone had diagnostic tests 7 months, I would really probably suggest repeating that, because you might still have a little bit of effect from the Botox. And we definitely don't suggest Botox with myasthenia gravis.
Thank you. Another question that we have from Catherine is, my AChR binding test was 0.49, but positive is 0.50. The thoracic surgeon I consulted with called me seronegative. Does 0.01 make that much difference? How is the top equivocal or equal to seronegative?
So what I would probably suggest is repeating the test when it's right on the borderline. And one of the things that we look for is the most common acetylcholine receptor antibody we look at is the binding, but we also look for the blocking and the modulating. So it would be worthwhile to repeat and then to also make sure that we're doing the other studies, like the repetitive nerve stimulation, single fiber EMG. And the person should probably also see a neurologist to make that diagnosis. So the specialist is the for the chest and thymomas and thymic hyperplasia is the thoracic surgeon. But in terms of making the diagnosis, I would suggest the neurologist make that diagnosis.
Thank you. A question from Heather. Does it make a difference which muscle is tested for single fiber EMG?
It does. You want a muscle that's weak. So one of the muscles that we often will do is something called, there's an extensor muscle in the forearm that raises the fingers. So finger extension is one of the muscles that are often weak with myasthenia. So you want to go for a weak muscle. We also will often do the face, a small facial muscle.
Just one moment. I'm pulling a few more questions.
Do you have one for Sherry? Sherry needs a question.
I'm sure there is one. We actually have quite a few.
Good.
So I'm sure there's plenty in there. So another question we received is, how effective can Solaris be?
So Solaris is very effective with the acetylcholine receptor positive, the seropositive. It does have its own risk profile. For seronegative, we have no data. So we don't know how it would be in treating a seronegative individual. One thing that we do know is that thinking about the pathophysiology of MuSK-positive and myasthenia gravis, we don't believe that it would be effective with these individuals because complement is not part of the pathophysiology. So as clinicians, some of the things that we're looking at is in individuals that are seronegative, should we be looking at assays of complement to see if there's problems with complement consumption, and would these be individuals who might be beneficial with Solaris? Are there other biomarkers that would predict response? So we don't know in the seronegative population how it would work.
A question that we have from Giselle is, my neurologist said she doesn't think it's MG because my single fiber EMG is negative and most of my bloods are negative. Except for a borderline MuSK, she's dismissing as non-specific. Could you make this information about single fiber EMG being positive on the diaphragm but not on the trapezia so I can bring that back to my neuro?
Now, you can, but places that do single fiber, or we don't do single fiber of the diaphragm, and I'm not aware of any center that would be doing single fiber of the diaphragm. I would say that there are many places that would not be able to do even the repetitive nerve stimulation of the diaphragm, because that's a more specialized test. So if you're going to have something like that done, you really need to be at one of the academic centers and not a community neurologist where they don't do things like that routinely.
I'm not on a computer. I butted in earlier. Can I ask a question? I'm sorry.
Sure, no problem.
I'm so sorry. I tested positive on my single fiber EMG test, and they did it on my, like right above my eye and like on my forearm.
Mm-hmm.
Is it normal that, I don't know if it was called Dieter or Jeters, I don't know what you call that.
Jitter.
But,
that's the jitter, yes.
Oh, jitter, okay. Is it normal that it came out more stronger or positive, like a weaker muscle on my eye area versus my forearm area? I mean, they both came out positive, but is that normal? I mean, does it mean my face muscles are just weaker, or I don't know if that's a stupid question.
Yeah, no, that's actually a very good question. So this is a snowflake disease. So as you know, myasthenia can present, most people present with a drooping eyelid or double vision at their onset, but there's still a large percentage of people who present with just swallowing problems, just breathing problems, or just limb weakness. So everybody is different. And so even though we say most people do this, everyone is different. So the fact that yours is weaker in your forehead, and that is one of the muscles we typically do, suggests that your face is probably weaker than your forearm. And we actually, clinically, there are centers like Duke that will follow single fiber to understand where they are clinically with the severity of disease. So it is a good marker, and that's a good question.
Okay, thank you.
Another question that we have is, does a thymectomy improve ocular-only MG?
We don't have evidence for that yet. So, we have the evidence for generalized myasthenia gravis. And so many neurologists will not do thymectomy for ocular only. However, in saying that, about 15% of people have ocular only. So if someone is primarily ocular and then generalizes, then they will have benefit from the thymectomy.
A question from Janet. How do you convince your doctor to go beyond the blood test for testing like this?
So what I'd say is, first thing you want to do is make sure that you're seeing a neuromuscular specialist. And then you want to make sure that next step is, if you're not getting the answers and they're not looking beyond that, is to go to a specialist in myasthenia gravis to look and confirm the diagnosis. And then the next thing is a separate consultant. So I'm going to ask Sherry, where would you go?
Where would I go?
Or what would you do? What would you do?
Yeah, and so I've been in those situations more than once. So if I have a good relationship with my physician, I'm going to feel comfortable about asking for different testing, or just saying, hey, I heard about this test, or what would you think about this, and feel confident then that they would be willing to help me. If it is to a point where I am not feeling that I'm being heard, or that I'm being cared for, or that for some reason I'm not meshing well with my provider, then to me that is a sign for me that I need to look, at least getting a second opinion. And as Charlene said, looking for a neuromuscular doctor, or more specifically a myasthenia gravis specialist, which is essentially what I wound up doing. And so we just may have to keep searching, and oftentimes, at least at this point, that may involve some travel and may take some time getting in for an appointment. But in the end, we're going to be more confident in what answers that we receive.
Another question that we have is IBS and or migraines associated with MG?
No. Now, I said that quick. So in terms of migraine headaches themselves, they are very distinct. But I find that many of my individuals I'm treating with myasthenia may have some more tension headaches or discomfort at the back of the head and the neck because of the neck weakness. So they can tell when symptoms are bad because they start getting discomfort, like, oh, and then with a little bit of support, a little bit of rest of the head and neck area, that discomfort goes down. In terms of IBS, it's not directly associated with myasthenia, but many people with myasthenia have other autoimmune diseases. So it may be, that may be the link to their IBS. And then another point is Methanol often causes diarrhea, cramping, and so maybe that's not IBS. That may be your Methanol. So make sure you take it with food.
A question from Annie is, do you know when the blood test for LRP4 and agrin is going to be available?
That's one of the things that I'm hoping to get. A lot of times we have it available and then it keeps moving. So one of the places that, the last place I heard that we're doing it is in Cleveland. So that's where it is now.
A question from Banda. In your experience, are seronegative patients more resistant to treatments?
You know what? The seronegatives, I have my gut response to that would be, one, if they're resistant to treatment, it's probably not the right diagnosis. So maybe we're not doing the right thing. And I don't know if the question is asking if someone has severe symptoms, are they more or less likely to respond? Many seronegative myasthenia respond just like the seropositive, and there are people who are more refractory to treatments, and it takes Methanol, steroids, steroid-sparing drugs, IVIG, or plasmapheresis intermittently to manage their symptoms, and now Solaris for seropositive. And for the musk, we're using the Rituxan. So there are, as we're getting newer agents, I think we're going to be better able to treat.
Another question that we have, it's a two-part question that I think would be great for both Sherry and Charlene, if you would be able to chime in. So one question that came from Lily is, do your colleagues acknowledge seronegative MG? How do you deal with doctors that are skeptical? Another kind of related question is, how often do you believe that doctors don't believe in seronegative MG, and how do we as patients advocate for proper testing?
So we in the neuromuscular group believe in seronegative, and as myasthenia experts, we believe in seronegative myasthenia. So I would say search for a specialist who can help you.
Yeah, and I think we kind of covered that in another question of what might lead you to feel the need to search for a second opinion or someone else that can help.
And I'm honest with many of my patients. So when it takes me longer with a seronegative, because we're not just talking about treatment, and treatment response, how are you doing with your medicines? We're actually sort of restarting, rethinking things. Anything new, is there, and as we go off to conferences, I'm learning new things all the time. So it's making sure that, are we not missing some diagnosis? So I'm always back on that diagnostic step.
A question from Leah, is CellCept ever contraindicated with patients with a pre-existing immunodeficiency such as CVID?
So that's a difficult thing. So everything we do has a risk benefit. So the CVID is a combined immunodeficiency where someone is missing the immunoglobulins and they're more prone to infections. The CellCept and azathioprine or Imuran and many of these medications affect the B and the T cells, and so when you use these agents, you're making them less effective, and as you're doing that, some of them make it it would make it harder for them to make immunoglobulin, and you're going to make them even more predisposed to infection. So with the primary immunodeficiency, many individuals are treated with IVIG for that condition, and that may help the myasthenia. So that's a condition where someone may get longer-term IVIG therapy for the immunodeficiency.
A question from Heidi, and then I think we'll probably do 2 more after that. We do have quite a few questions, so we probably won't have all the time to get through it. But one nice thing is that we're probably going to do a follow-up to this session. So there will be an opportunity. I can post those. I can share those questions with the speakers, and then they could look and see if there's ways to integrate it into a follow-up presentation.
That's great.
So question that we have is, are there any other therapies that are indicated if all the ones listed, Methanol, immunosuppression, and plasmapheresis, have very limited benefits? Is there anything up and coming?
Well, there's, I actually switched off to my last slide here, so I'm going to change that a little bit. So, one, I want to thank everyone. The webinars are a great place to get information, and I want to thank everyone. We had like 70 people, maybe 80 at one point before we had all the glitches, for being a part of this. And one of the things we'd like to do is really help us identify your needs. So if there are things you would like to see webinars related to or informational pamphlets, make sure that you let us know at MGFA, and we'd like to address those needs. I want to make a push for the MG registry. I think this is very important, and I think the population that we really need to collect a lot of information on is the seronegative. And I think as we understand what are the differences, what are the similarities, how do they respond to treatment different or the same? Are there certain clinical features that will make us think that someone has myasthenia but they're seronegative? Should we be looking for other things? I think it's so important to do the registry. We've had a number of quality kind of studies and questions about what life is like living with seronegative and seropositive MG. As we build this registry, we can get pharma interested in opening our trials to seronegative. This is one way. The current studies are only open to MuSK positive and seronegative. There are a few that are opening, including some seronegative, but also being an advocate for making sure we get care, make sure that you have access insurance-wise, and making sure there's availability to care. It's important to share your stories, as Sherry did today. I thought it was very important to set the stage for the journey, the difficult journey that you all go through with seronegative and the large number of tests, the struggle to get the care you need. I think it's important because it lets people know that you're not alone. It helps us advocate, and it may help not only empower you, but empower others. The MG Friends has support networks, and then we would love to see you all at the national conference, and we have sections on seronegative. So we would love to invite you to come to Atlanta. So, Jessica, can you repeat that question? Because I wanted to get to this slide.
No problem, not at all. So the question, and that was actually a great lead-in, so it is related. The question that we had from Heidi was basically, are there new treatments on the horizon, since the current ones don't really don't produce the results for many folks?
Well, the the big question is, so the Solaris came out very positive for the seropositive myasthenia. And so the question is, on an off-label basis, will we be able to test it in those that have refractory MG who are seronegative? And that's going to be a tough thing. It's a very costly drug. The insurance are not paying. You have to meet the criteria to use it properly as it was tested for. So, so there may be new studies down the pipeline.
And just adding that the registry, again, is probably our best advocate for things like that for the seronegative community, if they can see how many of us there are out there, and if our treatments, if we need different treatments than what we're able to get, that I would say that is probably the best thing we can do to help promote companies to do that.
We'll do one more question, just because we do have quite a few. This one we covered a little bit. So it is related to patient advocacy, but is there any special tips that you can provide for somebody who's in the emergency room in terms of being a good self-advocate?
So I'm going to take it, and then I'll let Sherry do it. But one of the things that I think is important is with myasthenia, the things that we really need to treat are the shortness of breath and trouble breathing. And this is a universal problem with myasthenia. Going to the emergency room, if you don't have wheezing, you don't have asthma. If you don't have EKG changes, you're not having an MI. If we look for pulmonary embolus, which is a blood clot in the lungs. So there's a few things, and we look for heart failure. If you don't have those things, it's not on the things that most general practitioners are used to treating. And myasthenia, we are all taught about it as physicians, but it's not on the tip of our tongue, and we often patients or physicians, we're trying to get a lot of education out to our emergency colleagues, but we'd like to make sure that they know how to treat patients well. So one thing that I like to do is guide the way. So if one of my patients is going to the emergency room, they call 911, they go. On the way, they make a phone call, or their family makes a phone call to the neurologist. And what should happen is you need to call the team and say, I have a patient coming, because you don't want someone with myasthenia sitting in the waiting room and unobserved. So I like to get my patients at least back where I can have them observed. I want them closer to the nurse's station. And then understanding that it's the pulse ox, which measures oxygen, is going to be a late sign, so we want to make sure that they understand how to assess breathing difficulties properly. So what I say is you need your physician to help guide what they want to have done at the emergency room. And I think that helps the emergency physicians have the confidence to treat myasthenia well.
I think that's an awesome plan to be able to have, to have that plan set ahead of time with your neurologist. What do I do in an emergency? My neurologist writes down, if there's any change in my patient's condition, please notify me immediately. I carry this around with me and a hard copy and a copy on my phone all the time. And we also, boy, this is such a huge topic, and sort of going over some of the later slides that we're not getting to tonight might be a good topic for future. But having a trained advocate with you, whether it's a spouse or a family member or a friend, to be able to help you navigate these things, make a phone call for you, and tell the emergency staff, this neurologist needs to be notified, and, here's his request of being here, his or her request of being notified. I'm sorry, I am getting really weak sitting here, and so
it's time to go.
Yeah,
but thanks.
I am not coming through with some good things here. This is really, it's a really important question, so I apologize. But actually, I there. Charlene,
Jessica, what, Jessica? As I'm looking, it's time to finish up, but you know what? Do we get to have the chat? Does that come with the webinar? Like, does it get posted with the webinar? Because there's a lot of good suggestions that are floating up here now that I have time to take a look at the chat room. Have your MedAlert bracelet, and make sure that you have your emergency list with you. So will those go with the webinar, or how does that work?
So we won't see those with the webinar, but I've copied all of the questions that have come through the chat box, so I'll share those with both of you afterwards, so you will be able to see the questions. One thing that I'll mention is that there has been excellent feedback as I'm going through. People have said this was fantastic. Somebody actually said this was the best doctor visit that they've ever had. People are very eager to have a part 2. So I thank you both in advance for agreeing to do another session down the road to cover the treatment options and other things. So everyone, the response has been positive. Thank you all so much.
And it looks like you've had very active participants, so I'm excited about the folks joining. So
yes. So thank you so much.
All right. Well, good. Thank you.
All right. Bye-bye.
Thank you, Cheryl. Thank you, Dr. Hafer-Macko. Thank you all of our participants for joining. I did share a link about the MGFA National Conference, which is coming up at the end of March. If you're able to join us, you can check out the website, see more information, get registered there, or you can reach out to us as well at the national office. But we thank you all for your time. I am very sorry for the audio issues that we had at the beginning, but I'm glad that you all kind of stuck with us to hear such a great program.
Yes, thank you all for your participation. Good night.
Thank you, everyone. Bye-bye.
Have a good evening.
Good night.